Thank you very much. So I think we're a little bit late, so I'm gonna go a little bit through this. Yeah, so there's always this dichotomy between, lifestyle or can we solve the problem with lifestyle changes and diet alone? So I think this is a crucial question. So it's clear that weight loss can improve the liver disease in NASH. That's quite clear, and you see here a little bit that depending on how much weight you lose, you can improve almost everything, including fibrosis, but then you have to lose a lot of weight, at least 10% of the body weight. But it is achievable, and actually, if you look at one of the best studies that specifically implemented a one-year program of diet and lifestyle changes, you can see that if you're able to achieve weight loss, and the more weight loss you achieve, the higher the probability to. So how do you point here? Oh, that's like that. So the higher the probability, you'll go from 10% to almost 90% resolution of NASH, which of course, for the moment, no drug can achieve. So, but there is a temptation to believe that this can solve the problem by itself. So in the next 2 or 3 slides, I will try to show you that there are limitations to this approach. So the first limitation is, of course, that it's very difficult to implement for the doctors, and it's very difficult to maintain and sustain for the patients. You need clearly, we lack specialized resources for implementing it. We don't have the knowledge, we don't have the time to explain the patients in an efficient way. Then there's a lot of individual variability in the metabolic response. Some people can easily lose weight, others no, and we talked about that a little bit yesterday. Interestingly, there's physiological ways to adapt to weight loss. So the body senses there's weight loss, and then it tries to bring the weight back. There are counter-regulatory mechanisms, essentially based on hormonal imbalances, that tend to increase appetite so that the body gains the same weight, even though you lost weight through an intervention. But one of the things I would like to, and of course there's the problem of sustainability over long periods of time, but one of the things I would try to insist upon is the fact that maybe patients that have the more severe disease get the least benefit from dietary and lifestyle interventions. Because if you look here at, say for instance, changes in fibrosis, okay? Changes in fibrosis depending on weight loss. So of course you lose more than 10%, you improve fibrosis. But if you look carefully enough, only half of the people improve fibrosis. And actually, the correlation is not that perfect. If you look here, so some people lose weight and they still worsen fibrosis, and then some other patients is the same here. So some people gain weight and still regress fibrosis. So all in one, only half of patients that achieve this very high rate of weight loss do really improve fibrosis. So there's just already some uncertainty here whether some patients benefit less than others. And then if you consider, for instance, NASH resolution instead of fibrosis. You look at NASH resolution, which is a real easy thing to obtain with a lot of weight loss, you realize that if you stratify patients based on the severity of their disease, the more severe the disease, the less you get NASH resolution, even though you lose weight. So for instance, if you have diabetes here, so resolution of NASH, okay? If you're a diabetic, resolution of NASH is only 23%. If you're not diabetic, resolution of NASH is 32%. So you see you can lose here 10% points depending on the diabetic status. Now look here at severity of the activity of NASH, okay? So if you have mild NASH, 46% resolution of steatohepatitis. If you have active NASH, only 15%. So the more severe the disease, the less you can do resolution of steatohepatitis. And also here about, same thing about achieving ALT normalization. So, and the same in patients who are older than 46. So if you have severe phenotypic NASH or severe histological NASH, then the impact of weight loss is less, especially in terms of NASH resolution, and we have seen previously on NASH fibrosis. So yes, diet and lifestyle modification, difficult to perform and implement. We need much more diverse and expert teams to do that. And sometimes it's not enough. Now, if we move a bit more specifically, and we had a very good talk yesterday, so I'm not going to go through this, just a few points regarding diet. So of course, there are so many different diets. In the end, people agree that the best one is the sort of Mediterranean diet. It does have cardiovascular benefit. You can see here clearly. That's in terms of cardiovascular events. So this is just it's the same graph, but on a different scale. But what is interesting is that as far as the liver, the Mediterranean diet is able to improve liver fat, and that's independent of weight loss. So even though people don't visibly lose weight, they might still improve the amount of liver fat with this type of diet. So this is important to understand. The other thing is that there have been some studies, there are retrospective studies, not very good quality, but they tend to show that there might be an impact on HCC reduction as well. Now, what is interesting here, and this is some new data, is that the impact of the Mediterranean diet on cardiovascular risk is mediated through steatosis reduction. And the demonstration comes from one of these studies here that was intended for a different purpose, but they did a sub-study looking at liver fat. And they compared a low-fat diet with a Mediterranean diet, okay? And both diets were able to reduce cardiovascular risk. But if you look carefully enough, the instances where the cardiovascular risk was most reduced were the same ones where the liver fat was most reduced. And if the diet was not able to reduce in people, especially a low-fat diet here, the reduction in liver fat was much less than with Mediterranean diet. And consequently, the reduction in cardiovascular risk was also less. So this goes back to the talk we just had, which is probably liver fat is a major mediator of cardiovascular outcomes. And most of the benefit goes together with a reduction in liver fat. So that I find this interesting. This was an 18-month study comparing the two. Another thing that I would like to point out, I think there was some allusion to this yesterday, some hints of the importance of snacking yesterday. So snacking is very bad. So even if you look at the same amount of calories you eat each day, if you snack versus just eating 3 meals, this is detrimental for the liver in terms of liver fat. Same amount of calories. But if you fraction that throughout the day, you will end up building more fat in the liver because you keep putting a pressure on the pancreas and on insulin secretion. So, for instance, you look here, this is all in humans. You look here on a high sucrose diet, and this is a regular diet versus a fraction diet. So they have 5 or 6 meals a day, they have 3 meals a day. And you see here the large difference in the increase in hepatic fat content. And the same for a high fructose, high sucrose diet. Single versus fraction, big increase here. So snacking is not good. Then there's another thing that I find very interesting is about exercise. So exercise reduces liver fat, but it also reduces visceral fat. And this is well known. But what is not well known is how does exercise reduce visceral fat? And what are the mediators? Because exercise is mainly happening in the muscle, and then there are effects on fat, which is a totally different compartment. And this is a very interesting study performed on a small group of patients, but that compared people who exercise versus people who are inactive. And then among people in each group, exercise or inactive, half of people were treated with an anti-IL-6 antibody, which is, by the way, it's called tocilizumab, and it is used in, I don't remember in what, maybe psoriasis or rheumatoid arthritis. And interestingly, people who had, who exercised, right, they had a reduction in visceral adipose tissue. That's well known. But if the same people were treated with an antibody that blocks IL-6, there was no more reduction in visceral adipose tissue. So which means that IL-6, which is synthesized by the muscle during exercise, has a very important role in reducing the amount of fat. And if you block it, you won't have the reduction in liver fat. So this is, again, the crosstalk between organs is extremely important here, and IL-6 is a very important pro-inflammatory, insulin sensitizing, actually favors insulin-resistant cytokine that mediates that. So I find this particularly interesting here. Now, another thing that I would like to point out is it too late to exercise and to implement diet once you already reached the cirrhotic stage, right? Because you could say, well, what's the point? It's the last stage of liver disease, so maybe it doesn't matter anymore. So we don't have much data, but at least we have this very nice study, comes from, I don't know where it was before, I don't remember. Annalisa Berzigotti is from Switzerland, but I don't know where the study specifically was done. But they looked at people with compensated cirrhosis, not only NASH, any etiology. And these people had portal hypertension. They were overweight. And they were entered in a program of reduced caloric intake and exercise weekly, okay? And what is interesting is that even in these people with advanced disease, because they have, portal hypertension, fixed cirrhosis, that program was able to reduce portal hypertension. Not by much, actually a little, but still significantly. And 42% of them had a reduction in portal hypertension that is compatible pretty much with what is considered to be a risk reduction in visceral bleeding, that what you want to achieve when you put people on beta blockers. So it tells you, first of all, that's feasible. In some patients, they have to be fit. And second, that you might still get benefit even in this advanced stage of liver disease. Now, if we look in exercise in general, those are really fascinating data from very large databases from the Far East. And you can see that exercising reduces all-cause mortality and cancer mortality. But what is striking here is that it reduces that even small amounts of exercise, not spending 1 hour at the gym, even 15 minutes is better than nothing because there is a significant reduction. And then, of course, the more time you spend, that 15 minutes is here, right? But then the more time you spend doing exercise, the higher the benefit. And that's for moderate exercise. Of course, if you do vigorous exercise, like here, the benefit is even higher. So that is fascinating because there's an impact on mortality. But there's also an impact on cancer mortality, which is really very, very unusual to obtain that. It's better than anything sorafenib did or all these other immunotherapies. And it has been calculated that any additional 15 minutes exercise time period clearly reduces has a measurable impact on all-cause mortality and cancer mortality. So there is hope here. You don't have to be taking a lot of time doing this, and small amounts of exercise is already better than just being inactive. So therefore, it is difficult to sort of find out for each individual patient what is he going to benefit most? Is it just from dietary and lifestyle measures, knowing that it's difficult to implement, sometimes too late, and when it is necessary to go to the drugs. So that is one of the problems in the field, is that we need to better understand who will benefit from drugs and who not. There are no drugs on the market, okay, for NASH that everybody knows, but there's some data with some stuff that people tried. They tried pioglitazone, vitamin E, UDCA, liraglutide, pentoxifillin, orlistat, and so and so. And there's rationale for some of them, strong rationale for some of them, weak rationale for others. Level of evidence, so high efficacy, low efficacy, depending on how many studies and what the effect was. There are some side effects, and the drugs that have the best evidence for so far have also most side effects, and some of the side effects, like weight gain, are not really good for patients with NASH. But the point of this slide is the following, is that none of this we're sure it really works. None. And why are we not sure it works? Because there's been no well-conducted phase 3 trial for any of these drugs. This is all investigator-initiated studies, not performed very professionally, not performed with a required level of rigor in terms of methodology, statistical analysis, statistical calculations, sample size calculations, nothing. So the definitive demonstration, you cannot be sure these work until you have a really well-conducted phase 3. So people jump to conclusions all the time. You see a study on PO, PO works. No, you would not jump to conclusions for drugs in development that easily. You would want a phase 2, you want a phase 3, you want a strong documentation. Well, the same standards need to be applied to these drugs, and they would all fail. So just some of the recent data here, for instance, vitamin E, everybody says, yeah, vitamin E works for NASH and so on. So there's very little evidence actually vitamin E works. And the latest study shows that it doesn't work at all as we would suspect. Because in this study here, that compared vitamin E alone versus placebo versus the combination with PO, you can see that you're talking about, for instance, NASH reduction, which is not so difficult to achieve. Not a strong difference with placebo actually was not significant here, whereas PO and vitamin E, yes. And the same for NASH resolution. No difference for vitamin E alone. And then fibrosis, forget it. Absolutely no difference for fibrosis. So PO plus vitamin E might be better than placebo, but that's not because of vitamin E, it's because of PO. Now, we also need to acknowledge those are very small studies. They're not powered at all, so there might be a difference that is not picked up because of insufficient sample size. But at the same time, we have some retrospective data that suggests that there might be some benefit of vitamin E. So you will see a few slides on this, and I want to draw your attention to the fact that this is not coming from randomized controlled trials. It's coming from retrospective analysis of data, so very important. But again, people, they see differences here, they jump to conclusions. But this is not the methodology to say a drug is working. However, it does give you some indication that there might be something happening here. So basically what they do is that this is a retrospective analysis. They look at all people who had cirrhosis or advanced fibrosis. And among these, they looked at those that received vitamin E for more than 2 years. And then they compare them to matched controls. So it's not randomized, it's nothing. It's just retrospective analysis. And they look for a few years of follow-up, which is good, because that. And then they realized that people who were exposed to vitamin E had less reasons to go for orthotopic liver transplantation. So alt-free survival was higher, and they have less hepatic decompensation, as you can see here. So that's interesting. There might be that these people with advanced liver disease, again, F3, F4, if maybe there's some benefit in having them on vitamin E on hard clinical outcomes, but maybe not. Maybe they're very different from controls, even though there was ways to try to have populations that are comparable. Now, same thing for metformin. Metformin has been suspected to reduce risk of liver cancer, but based on the same methodology, except that we have more studies. And this is a study that is performed actually by the same team in Indiana, at the Indiana University that has performed the other study. And they did the same thing. They looked at people with F3, F4, and instead of looking now if they were on vitamin E, they looked at whether they were on metformin, and they had matched controls. And again, same findings, less need for transplantation, less hepatic decompensation. But this time, there's also less hepatocellular carcinoma. And this actually is in line with what was found by other people. This is another study, different group, that looks at people with diabetes that develop cirrhosis due to NASH. So once they have cirrhosis, the diabetologists want to stop metformin. Well, it seems to be a mistake because those that continued metformin, despite being at a cirrhotic stage, had a better survival. And then there are studies, not performed by hepatologists, but by the diabetologists, that retrospectively look at the risk of liver cancer in metformin-treated patients. And most of them show that people that were treated with metformin had less risk to develop liver cancer. Again, it's not a randomized controlled trial. But this sort of confirms this result here. So we start having quite a few data accumulating on the possibility that metformin might have an impact on cancer. And then there's the whole story of statins. Same thing. Retrospective analysis has shown benefits for statins. Liver cancer, complication of cirrhosis, portal hypertension, even maybe reduced fibrogenesis. There's quite a few data on that, on statins. So that's why I think there are some drugs that have not shown direct benefit in NASH, but might have collateral benefits. And the same thing stands true for GLP-1 receptor agonists, like liraglutide, semaglutide, and SGLT2 inhibitors, like EMPA, DAPA, canagliflozin. because they reduce cardiovascular mortality and events. So it might be good to give them to NASH patients for all these reasons here as well. So drugs in development can be classified in different families. You have a lot of metabolic drugs. You have very few anti-inflammatory, anti-fibrotic drugs. Metabolic drugs can be also subclassified in FXR along the FXR-FGF19 axis, or among the PPAR axis, PPAR activators. Or then there are purely metabolic drugs that interfere with lipogenesis or with fat distribution. Then you have weight loss drugs, or drugs that are being marketed for diabetes and that induce weight loss. And then you have all these poor parent of hepatology or NASH research now, which are the anti-inflammatory, anti-fibrotic drugs. And you can see here the names of these compounds and I would say the sponsors, I would say the people who develop them. Now, one important, oh shoot, I think I'm missing a slide. But anyway, one important thing to understand is that people always want to see fibrosis improvement, okay? That's everybody, the only thing people care about. Now, you could see fibrosis improvement directly by using, anti-fibrotic drugs, except that we don't have any that work, and most that have been tested are negative. Now, there's another way to improve fibrosis, is by treating the primary cause of the liver disease. So, for instance, the best results we have with anti-fibrotic results was with drugs that were antivirals, that interfered with viral replication and had zero effect on fibrogenic response in the liver, zero. And yet, those are the drugs that achieve the best antifibrotic response. HBV, HCV, we saw cases of cirrhosis regressing with all these drugs that are mentioned here. So therefore, the paradigm here is that you can improve fibrosis directly, but you can also improve it indirectly by getting rid of the cause of liver disease. And it might be the same for NASH. Maybe that if you have a drug that interferes with NASH and induces NASH resolution, then you'll have an effect on fibrosis if you wait long enough. Because in the end, what causes fibrosis in NASH, and that's what people don't understand, is because they say NASH is not important, only fibrosis is in terms of prognostic. That's a total misunderstanding of the field, and actually the whole way hepatology works, because in all chronic liver conditions, you only get fibrosis because you get liver cell injury and inflammation in the liver, okay? And that's been well known for all causes of everything. And in particular for NASH, if you start thinking about it, it's a little bit like having a train, and the engine of the train, the one that moves it, is the necroinflammatory component of the disease, which here is steatohepatitis. And the more active steatohepatitis, the stronger the engine. And then what does the engine is that it moves the train along a track, along a distance, right? And if you reach the different milestones here, those are different stages of fibrosis, that's the longer the distance. And here is cirrhosis. So what is interesting is that if you want to stop this whole thing here, you could put the brakes, which is equivalent to giving an antifibrotic treatment, but you could also cut the engine, which is equivalent of treating NASH. And if you cut the engine, what's going to happen here is that the train will slowly move backwards on this uphill trajectory here, will move backwards, and fibrosis will regress. But for some reason, people have trouble understanding this whole concept. And we have now a lot of data showing that, at least from natural history, that people who have regressed from NASH to fatty liver, or from NASH to NAFLD, or simply people who have a regression in the activity score have less progression of fibrosis. And the opposite is also true. And there's data from natural history, people with 2 biopsies. There's also data from interventional studies, like the trial of elafibranor, but there's no time to develop that. So this in mind, the 2 objectives that we want to achieve with these new drugs is, of course, in the end, to have less cirrhosis. But that takes time, so you need interim endpoints. And the interim endpoints usually are measured at 1 year or 1.5 years. And the interim endpoints cannot be development of cirrhosis because it takes longer than that. So you have to settle for intermediate sort of endpoints, which are NASH resolution, for the reasons I explained, and fibrosis improvement. And the first large data set we have that has released data so far is the REGENERATE study, which tested obeticholic acid. And this is the first phase 3 with positive results. The results were analyzed at month 18. And they clearly show that the high dose of OCA over placebo significantly improves fibrosis, one-stage improvement. And the difference is even higher if you look in people who, per protocol, meaning people who really had the 2 biopsies. And we can discuss about that later. What is interesting in this data here is it's probably not an artifact because, first, because it's a large study, but second, because if you look at the proportion of people who improved is higher than placebo, and then this here, but then the proportion of people who worsened is lower than placebo. So it all goes in the same direction. This is very important to look at both aspects, both directions. Then you have, there's the effect on NASH resolution. Unfortunately, there was no difference in terms of NASH resolution, which is kind of strange. But I think it all depends on how you measure it, and depending on what type of score you apply, you can see results showing. And here, for instance, a different way of looking at NASH resolution, there's a significant difference here. Now, if you look at data including all patients in this trial, so meaning including F1 patients, then there is a difference in NASH resolution for all categories. Second compound in development is in phase 3, is elafibranor. So this is totally different. It's still a nuclear transcription factor modulator, but it's no longer FXR, it's PPAR. So PPAR, you have alpha, delta, gamma, okay? Gamma, it's easy, is the glitazones, PO, ROSI. But then alpha, it's easy, is the fibrates that we use for fenofibrate, for instance, hypertriglyceridemia for many years. And delta, there's no drug for delta so far. But then alpha and delta combined is interesting because you get both an effect on burning fat and an anti-inflammatory effect, to make it simple. And this particular compound is really targeted to the liver, and it has no PPAR gamma activity. And it has been shown in numerous phase 2 studies that it has a very strong metabolic effect on lipid side, on glucose side, on visceral adiposity, and so on. And it brings down aminotransferases. So based on that, there was a whole phase 2B trial. I think some of you, Manuel was part of that as well, that tested 2 doses versus placebo. And the results, that was done a few years ago, the results is that in an intention to treat analysis, with the current definition of NASH resolution, there was a difference versus placebo that was significant. Not a very strong difference, but significant enough. And then the more severe the disease, active NASH with fibrosis, the more higher the level of significance. So based on that, there's a phase 3 trial that's ongoing, and we'll probably have the results early next year. Now, the advantage of this molecule compared to the previous one is that you get some good effect on the lipid aspects. You see improvement in the bad lipids and improvement also in the good lipids. And then you also get a result on all the insulin resistance glycemic parameters. So basically, reduction in LDL, increase in HDL, reduction in Lp(a), and then a reduction in HbA1c. And that's remarkable because all these people are already treated for diabetes, so you get that on top of what's already being implemented. Third drug that is in phase 3, the trial is starting now, totally different. It's a thyromimetic, so it mimics thyroid hormones. But you can't just mimic thyroid hormones because you're going to get all the side effects that come with hyperthyroidism, okay? So you don't want to have that. You want to have side effects in the liver only. You want to have efficacy in the liver only. So what happens is that, and I don't have time to show the data, but believe me, there is literature showing that the more liver disease you have, the more inflammation you have in the liver, the more the liver is in a state of hypothyroidism. Very interesting. So necrosis, inflammation in the liver, makes it so that you have less active thyroid hormones in the liver. So therefore, the idea here is to create a drug that acts like thyroid hormones, acts only on the liver receptor, which is the beta receptor, and not on the cardiovascular receptor, which is the alpha receptor, so targeted to the liver. If you can do a selective thyromimetic like that, then you might get the beneficial effects on the liver without the side effects. And there are several attempts to build such thyromimetic. Most of them failed because they're not sufficiently selective. But this here, called resmetirom, is very selective. That's what they say, on the beta receptor. And it has a very strong effect on lipids. So this was tested in NASH. The study is now published in The Lancet. And you get a very strong reduction in liver fat here. with this drug versus placebo. And you also get a very strong reduction in the different lipids here, LDL, ApoB, triglycerides. ApoB is highly atherogenic, LDL also depending on particles, Lp(a), and all this. So strong reduction in lipids, strong reduction in liver fat. And the orange bars here show that some people are more exposed than others. So if you look at people who have the highest exposure, they also have the highest efficacy. Now, does that translate into histological improvement? The answer is yes. You can compare here people who are on resmetirom versus placebo, 27% NASH resolution versus 6% only. And unfortunately, no effect was seen here on fibrosis. Why? I don't know, but this was a short study, only 36 weeks, and it was not really designed for fibrosis improvement. So the way you design it and the type of people you put in the trial can change the result. Fourth study that it will enter phase 3 in the next few weeks is Aramcol. So what is Aramcol? Is an SCD1 modulator. What is SCD1? It's a very important enzyme in hepatic lipogenesis, steroyl-CoA desaturase. So if you inhibit, and that has been done in rodents, if you inhibit this enzyme here, even though you feed the animals with a high energy diet, high fat diet, they don't develop obesity, or they develop less. They develop less adiposity, they're more insulin sensitive, and they have less fat in the liver, just by changing this enzyme here. And there's also some data showing that if you inhibit this enzyme, you end up burning more fat in the mitochondria through beta oxidation. So resistance to obesity-induced fatty liver and more lipid disposal in the liver. So therefore, a compound that is able to inactivate SCD1 was created. It's a hybrid molecule between a bile acid and a lipid. And this was tested in a large study in NASH patients, an international study performed on 4 different continents. And the results were reported last year. Surprisingly, there was a very strong effect on histology. You can see here a difference in the resolution of NASH. And there was also a very strong effect that went together on ALT reduction, as you can see here. And there was, it wasn't significant, but there was a suggestion of a stepwise increase in efficacy in terms of fibrosis reduction as well. But again, the study was not designed for fibrosis at all. Actually, all these endpoints were secondary endpoints. The main endpoint was on liver fat on imaging. But very promising results, and a phase 3 trial is going to start now. Very safe product. And finally, so we talked about what? We talked about OCA, elafibranor, resmetirom, and Aramcol. There's a fifth drug in phase 3, which is called senicriviroc, but we can talk about it orally, but there's no time to show a slide. The final slide is about the GLP-1 receptor agonists. That is very important because these drugs are already available. That's liraglutide. They have a very strong effect on weight loss, and they have a very strong effect on reducing cardiovascular outcomes. For those of you that think that cardiovascular death is the main cause of death in NASH patients, I don't think so, but most people think so. For those of you, then you would be tempted to use these drugs because it improves cardiovascular outcomes. Now, the problem is that most of them work essentially through weight loss, and weight loss is a little bit peripheral and mostly central, and we're not really sure whether they have specific hepatic effects. So remember the first slide I showed you on the Cuban study with people improving and some not improving despite weight loss? We don't know whether the same will hold here, but we clearly would like to have an effect beyond weight loss directly on the liver. So liraglutide, forget it, is not going to be developed for NASH. What will be developed is, on one hand, semaglutide, which is a stronger compound, but with side effects, and there is an oral form, and mostly we have injectables. And then you have, on the other hand, dual or even triple agonists. For instance, GLP-1 with FGF21 or GLP-1 with glucagon or GLP-1 with GIP. Those are dual agonists, some even are triple agonists that induce a very high rate of weight loss, and that would be very interesting to test for hepatic effects. So in conclusion, we're very fortunate this year because we had the positive results of the first phase 3 trial, which was positive for histological outcomes. It is very important to understand the interactions between steatohepatitis and fibrosis. So basically, steatohepatitis drives fibrosis. Drugs that are available on the market, we cannot make any solid recommendation for it. There might be drugs with collateral benefits, statins and metformin, so don't stop these. I don't say use these for NASH, but I say if the patient takes them, don't stop them. And make sure that if the patient needs a statin, he gets a statin. And there, of course, dietary and lifestyle changes are very important, but I think they're more important prophylactically than in a curative way. And then there's many promising drugs in development. Thank you.